Sorry about that, everyone. So I'm Dr. Andrew Skinner at Loyola University Medical Center just outside of Chicago. And thank you for the introduction, Jamie. So we'll be talking about the updating of the guidelines for the management of C. difficile infections, or Clostridioides difficile. And so my single disclosure, but we will not be discussing any products produced by Recursion. And so what are the goals that we want to have today while going over these? Over the past couple of years, there have been quite a few updates in the guidelines. And so the first is the update of the management of C. difficile from the IDSA and SHEA, which was released in 2021, which was then shortly followed up by the 2021 American College of Gastroenterology updates. And then shortly after that, followed up by the European Society of Clinical Microbiology and Infectious Diseases, also in 2021. And so we'll also get into a little bit of a couple of the future therapeutics. So what's the history of C. diff infections in the United States and how we've kind of recommended these things over the past couple of years? So if you go all the way back to the 1970s, back when it was still kind of in its infancy at that time, vancomycin was established as an effective treatment for pseudomembranous colitis. And the one thing you'll kind of notice as we go down this list is there's decades in between a lot of these recommendations that have released. And so all the way up until 1995, where a lot of hospitals at that time were trying to reduce the overall use of vancomycin due to the concern for vancomycin-resistant pathogens. And so that's when metronidazole really took the key position for treatment at that time. However, in 2010, when the SHEA and IDSA guidelines were released, vancomycin was changed to be the drug of choice for severe disease, but metronidazole was still a choice for mild to moderate disease as well. Then more recently in 2018 is when metronidazole was only recommended when vancomycin or fidaxomicin, which was released in the market into roughly around 2013, is the preferred choices. And then as of last year, fidaxomicin is now the preferred choice for therapy in initial episodes of C. difficile infection. And bezotoxumab was recommended for high-risk patients. And so these guidelines keep coming out in shorter and shorter intervals. And just a little bit of a backstory behind some of this is the initial guidelines that were released in 2021 were initially supposed to be a rapid update. However, when the team started to get rolling with before the recommendation was right about the time COVID hit at that time. So those guidelines ended up being delayed and it was hard to get to corral everyone into one group at that time as well. And so these are I'm going to list the resources that we'll be going over here. And so we have the IDSA and SHEA guidelines, the ACG guidelines, and then the European guidelines as well. And so starting with the IDSA guidelines. So this was the team that was put together to create the focused treatment update guidelines as well. So it was chaired by Dr. Stuart Johnson, who's also at the Hines VA, and then Valerie Laverne, who's at University of Montreal, was our bioinformaticist and biostatistician. And then other notable people, I would say Kevin Gary, Kieran Kelly, and Mark Wilcox, who is also on the European Society guidelines, and Anna Gonzalez Luna, and then myself. And so since the publication of the 2017 clinical practice guidelines, this was the big drive as to why they needed to have new updates as well, and pretty rapidly as well. That was with the advent of new data with fidaxomicin, and then also the addition of bezotoxumab, which is a monoclonal antibody targeting toxin B produced by C. difficile, which is the primary driver of pathogenesis. And so both of these agents were shown to have clinical efficacy and other advantages over the older agents such as metronidazole and vancomycin, but then the implementations of have been challenging due to monetary cost and logistics. And so what was the methodology when we put these guidelines together? So the evidence for recommendations was derived from topic-specific and systematic literature reviews. The systematic process followed, which included a standardized methodology, which is known as the grade process as well. And then outcomes of interest identified a priori by the panel, and then critical and important outcomes, which were presented in the summary findings table, were those that ultimately provided guidance on the optimal course of action. So The new grade definitions for a lot of these things have gone away from using weak recommendations and strong recommendations as well. So it's now considered a strong recommendation, which is we recommend, indicating a strong recommendation. And the implication of this is most individuals in this situation would want the recommended course of action, and only a small proportion would not, versus a conditional recommendation where we would say things such as we suggest, indicating a conditional recommendation. And the implication there is that the majority of individuals in the situation would want to suggest a course of action, but many would not. And that was to play into the factors such as the monetary and then the logistical implications, which I had just mentioned as well. And so all the literature for CDI treatment was reviewed through May of 2020, with the primary question of fidaxomicin versus vancomycin. In that, we reviewed roughly 3,600 articles, 18 full texts were reviewed, and then we kept 5 for qualitative analysis. And then for bezlotuximab, 239 articles were screened, 12 full texts were kept, and then 7 for qualitative analysis. Additional data were identified for other treatment entities, but the quality of the data was determined not sufficient to alter our current treatment recommendations. Just to keep in mind, we did not reassess recommendations for FMT, but noted that the FDA safety alerting documented transmissions of MBROs and pathogenic E. coli from a donor to FMT or recipients, and also concerns for transmission of SARS-CoV-2. And so the previous guidelines for the treatment of primary C. difficile infection included evidence from 2 large randomized comparator trials for fidaxomicin versus vancomycin, had over 1,000 patients, and the recommended vancomycin or fidaxomicin over metronidazole. Since that time, 2 additional randomized control trials comparing fidaxomicin to vancomycin were identified that were similar in design to the previous trials, but included only inpatients. And then one also compared what's known as the extended pulse fidaxomicin regimen, which is similar to the vancomycin pulse taper regimen that had been used in the past, with slight modifications that we'll go over in a little bit. And then the patient important outcomes that were considered were a sustained response, so 30 days after the end of therapy, initial clinical cure, which is 2 days after the end of therapy without any symptoms, drug adverse events, and then all-cause mortality. So first off, let's review a little bit again as to the why metronidazole was removed. So a lot of this information came from a study looking at a medication called tolvamir, which was tolvamir versus metronidazole versus vancomycin. And that kind of goes across here from left to right over here as well. And so it was a 2-to-1-to-1 ratio trial, and a combined analysis that included 563 patients treated with tolvamir. 289 received metronidazole, 266 received vancomycin. Results showed similar efficacy for tolvamir, which is not really important in this situation right now. The more important thing, though, was the efficacy of metronidazole was inferior to vancomycin, with 72.7 versus 81.1% having sustained clinical cure, with metronidazole only 72, vancomycin 81. And going into this a little bit further, more recently, there was a large meta-analysis involving roughly 5,300 patients and 13 different treatments for C. difficile infection. And metronidazole was revealed to be inferior to both vancomycin and fidaxomicin. We're looking at the odds ratio of sustained clinical response. So again, that's looking at patients or subjects who had sustained response at 30 days, meaning they did not have a recurrence after they were initially cured. The odds ratio that metronidazole resulted in a sustained response was 0.73 when compared to vancomycin, and then when compared to fidaxomicin was 0.49, indicating that it did not achieve the same results. And so what was the evidence summary for kind of the first question that we asked in the guidelines, which was, should fidaxomicin be used for primary C. difficile infections? And so looking at the sustained response of CDI for using fidaxomicin, we were able to show that the relative effect for fidaxomicin was 1.16 with a confidence interval of 1.09 to 1.24. But I know that most people don't really think of it that way, and so I want you to focus over more towards the right. And I think that kind of gives us a much more clear definition of as to why we recommended fidaxomicin over vancomycin. We were able to show that about 101 more sustained clinical response per 1,000 people, or 57 more to 151 more. So clearly, fidaxomicin was a stronger choice versus vancomycin. And the one thing that I always tell people to make sure that they keep in mind of is when we start looking at the initial clinical cure, there was no difference between vancomycin or fidaxomicin when it comes to the initial clinical cure. And why that's important is because of some of these logistical considerations that we still have to where fidaxomicin may not be readily available. People often ask us questions such as, wouldn't fidaxomicin be better to get them on right away? And the answer to that is not necessary. The big thing that fidaxomicin provides a benefit over vancomycin is going to be the sustained response for C. diff infection. The initial clinical cure, they're going to be about the same at that point, and there's never been shown to be any statistically significant difference between the two. So if you have a patient who needs to make sure that they have their symptoms under control, it's okay to start them on vancomycin to get their symptoms under control and then move them over to fidaxomicin once you're able to determine if it's a medication that would be available. And so these were the 4 main trials of just looking at vancomycin versus fidaxomicin. I know I mentioned 5 earlier, but I'm excluding it from this one here, and that's just because that was an extended pulse, and so these were the 4 that were roughly the same. And so here's where we're showing that in a forest plot, looking that it was a risk ratio of 1.16 favoring fidaxomicin. And so that's where we came up with these recommendations that oral fidaxomicin was the preferred agent over vancomycin. However, vancomycin was still an acceptable alternative, and that is because that was a moderate level of evidence with a conditional recommendation that fidaxomicin be used over vancomycin. Metronidazole was still considered a third alternative for non-severe C. diff infection, but from my personal experience and preference on that one, I would say that avoiding metronidazole at all costs should be the way to kind of treat these things going forward. And so the next question that we asked was, should fidaxomicin or fidaxomicin taper be used for individuals that are having recurrent diseases as well? So let's kind of highlight these 2 things for you here. And so when we're talking about patients with 1 or more recurrent episodes of C. difficile infection, using fidaxomicin or the fidaxomicin taper, which we'll go into, showed that the relative risk was, relative effect was 1.4 with a risk of 1.1 to 1.77. So 179 per 1,000 patients would receive a sustained cure at 30 days. And then at 90 days, it's about 299 per 1,000. Granted, that does have a much larger window, and a lot of that has to do with just the numbers of patients who are having 2 or more episodes of C. difficile infection in these clinical trials. And so that is where these next recommendations come from here. And so for the first occurrence, oral fidaxomicin again, or with the extended taper, which I'll outline on the next slide, is going to be 200 milligrams of BID for 5 days, followed by every other day for the following 20 days. So that still ends up being 20 tablets, which is what is typically prescribed in a standard prescription. And then after that, going down to oral vancomycin, taper and pulse regimen. And then for the secondary recurrence is where we're talking about doing the exact same thing. We did leave FMT on there. I know that I said that we didn't address that, but that was left on there as part of the 2017 guidelines as well. And again, these were conditional recommendations that we made, and it was a lower quality of evidence when looking at them. And so what is the extended pulse fidaxomicin regimen? And so this is where I said doing day 1 through 5, fidaxomicin is 200 milligrams twice daily. And then day 6 through 26 is 200 milligrams every other day. And from the extended fidaxomicin course, it showed roughly a 70% efficacy. And then versus the 10-day vancomycin course is 59% efficacy. Now, the one thing that we always have to keep in mind is this was compared to a standard vancomycin course. So it's only compared to a 10-day course of vancomycin. And there's still some trials ongoing looking at these vancomycin, taper, and pulse, but we do not have data on that yet. And here's just kind of looking at a graph form of the extended pulse fidaxomicin regimen. And so the trial included individuals age 60 and older, confirmed C. difficile infection in 86 different hospitals. This took place in Europe as well, so keep that in mind. But it was in Western Europe and then somewhat of Eastern Europe, so it should be a fairly comparable population. And so, as I noted, the IDSA recommended in patients with recurrent CDI episodes, we suggested fidaxomicin rather than a standard course of vancomycin, with a conditional recommendation with a low certainty of evidence. And then a vancomycin taper and pulse regimen or vancomycin as a standard course is an acceptable alternative for a first CDI recurrence. And then for multiple recurrences, the standard vancomycin is no longer listed, but a vancomycin taper and pulse regimen is listed. Another thing that always comes up when people ask what's the next step up in your treatment is always going to be whatever the treatment course was before that should be a step upwards at that time as well. So if for the primary episode, vancomycin 10 milligrams 125 milligrams 4 times a day was used for 10 days, then the next step up would be using fidaxomicin. And or using a vancomycin taper and pulse. You never want to keep going back and repeating the same thing because the likelihood of recurrence is going to continue to increase for every time these individuals do recur. And so bezuclastinib. So one of the new kids on the block at this point. And so it's a monoclonal antibody directed at toxin B of C. difficile. And it was approved in 2016 and indicated to reduce recurrence of C. difficile infection in patients 18 years of age or older, and are receiving also the standard of care antibiotics for C. difficile infection. So it is an adjuvant medication. It does have a half-life of 19 days, but the clinical effect goes upwards of about 12 weeks post-infusion. And as I said, it's an adjuvant and requires standard antibiotic treatment. So fidaxomicin, vancomycin, and they did also use metronidazole in the trial. And so just as a quick little introduction as to how this medication works. So I adopted this image from an article from Dr. Johnson of how the hypothesis of how this monoclonal antibody works. So on the bottom side, we have the antibiotic, which is in the systemic system because it is given as an IV. And then on the outside here, we have the colonic lumen, which has the C. difficile that is there. And so the proposed mechanism as to how this medication actually enters into the colonic lumen is that when the C. difficile infection takes place, it disrupts the tight junctions within the colon, which then allows for the monoclonal antibody to enter into the colon to bind to the C. difficile toxin, thereby reducing its inflammatory effect and reducing the risk of recurrence later on. And the thought process behind that is that you treat the initial C. difficile infection, and then after they have received the bezuclastinib infusion, they are going to, when they do potentially recur, that is when the bezuclastinib would be active. And so in patients with a CDI episode, should bezuclastinib be used as a co-intervention along standard of care antibiotics? So the evidence was from 2 large randomized controlled trials where bezuclastinib was administered in conjunction with antibiotics. And what were the outcomes that were measured? So recurrence at 3 months, associated hospital readmission within 1 month, drug-free adverse events within 1 month, and then all-cause mortality within 3 months. And so a subgroup analysis was identified for patients at higher risk also for recurrence, which was defined as age greater than 65, immunocompromised, severe CDI, and then prior CDI episodes within the past 6 months. So the overall data between these 2 trials, so going from left to right here, so they had also trialed out what's called actotoximab, which was to bind toxin A. So the combination of actotoximab, bezuclastinib is the first column. The deeper blue is just the Bezlo. Placebo is the next one, and then the actotoximab. And then, as you can see, is that from the individuals that received at least bezuclastinib, there was a reduction in patients who had recurrence as well. And then when we break it down based off those risk factors that I mentioned earlier, age greater than 65, immunocompromised, severe C. diff, you notice that the individuals with no risk factors, they had a benefit, but it wasn't that great between the two of them. It's not until you start seeing these risk factors pile up that we do notice a very large benefit for individuals who receive bezotoximab. So that is where we kind of come to these recommendations. So looking at CDI recurrence after initial clinical cure, we noted that the reduction in CDI recurrence was quite notable for individuals who had bezotoximab, with 125 fewer per 1,000 patients. And then also there was a decrease in the CDI-associated hospital readmission, with 61 fewer per 1,000 patients as well. And so that is where we kind of come to the guidelines for the IDSA-SHAE as well, to where we added an IV bezotoximab for first recurrence, and then also for second and subsequent recurrence. I would say from a practice standpoint, it is difficult to always get access to this medication if you don't already have a system in place to administer to patients, because it does require setting up an infusion center and then kind of wrangling logistics and getting things done over that time as well. And dealing with the cost of issues can sometimes be a problem, but we'll address that a little bit later. And so for patients with a recurrent CDI episode within the last 6 months, we suggest using bezotoximab as a co-intervention along with standard of care antibiotics rather than standard of care antibiotics alone. And so the certainty of evidence was very low in this situation, but it was still a conditional recommendation. And the recommendation places a high value on potential clinical benefits, but implementation is often limited by feasibility considerations. And settings where logistics is not an issue, patients with primary CDI and other risk factors for CDI recurrence that I mentioned, so age greater than 65, immunocompromised, severe C. diff, may benefit from receiving bezotoximab. And the patients without risk factors did not have significantly reduced recurrence from Bezlo. Data on the use of Bezlo when fidaxomicin, based off of the modified trial, was a little bit limited, with only about 35 patients actually receiving fidaxomicin during that trial. And the one thing to keep in consideration is that the FDA has a warning in patients with congestive heart failure, bezotoximab should be reserved for when the benefits outweigh the risk. There was no mechanistic reasoning as to why Bezlo resulted in some CHF exacerbations, but seemingly it did. And so what about some real-world publications that have described the experience since it's been released as well? So there have been 4 total publications that I was able to find through some of these things. And then so sustained clinical response at 12 weeks was achieved in 84% of the patients who had received. And then sustained clinical response at 12 weeks, about 84% in the Modify 1 and 2 trials. It had similar sustained clinical response in patients treated with vancomycin versus fidaxomicin in these real-world experiences, with fidaxomicin and vancomycin having 85 sustained clinical response. And then the sustained clinical response based on the risk factors as well, with age greater than 65 showing sustained clinical response of 86%, severe C. diff 83%, history of C. diff 84%, and then history of one previous C. diff at 91%, and then history of 2 or more C. diff infections at 78%. Oh, and then immunosuppressant 87. I apologize. And so here's our summary table at this time of what the IDSA and SHAE guidelines were. So just it's oral fidaxomicin would be preferred over vancomycin in the initial episode, but it is preferred an alternative, and it's a conditional recommendation, factoring in kind of the logistic and financial implications of this. And then for first recurrence, either fidaxomicin as a standard course or a tapered course, and then moving into the vancomycin taper and pulse, and then the addition of IV bezotoximab for all recurrences if there are certain risk factors. And so let's take a look at some of the ACG and the European guidelines when compared to the IDSA and SHAE updated. So the big thing that I'm going to focus on is going over treatment recommendations for initial and recurrent C. diff infections. There were several if-then recommendations for treatments of recurrent C. diff in the ACG and the European guidelines. We're not going to discuss a couple of the other things that were in there, and that is because it's too dense for what we're talking about, because they did also talk about diagnosis, treatment of severe C. diff, and then treatment of refractory C. diff, role of surgery, probiotics, so forth and so on. So here were the team put together for the ACG guidelines, and these were updated from 2013, and the recommendations were restricted to adults. Metronidazole was still recommended in non-severe low-risk patients, and they had several recommendations for fecal microbial transplant or FMT. And so looking at their initial recommendations, so they still had oral vancomycin and oral fidaxomicin as kind of the standard at this point, saying for initial non-severe episodes. And they also did make the mention of in non-severe, they could use metronidazole 500 milligrams as well. When they move up to severe, they did eliminate metronidazole as a treatment option. They did start to mention the use of fecal microbial transplants or FMTs on a case-by-case basis at that time as well. The one thing I will note and is that the quality of their evidence, they note, is low quality of evidence, but they did make strong recommendations on these. The overall number of randomized control trials for FMT is still quite limited at this time right now. And again, this is my own personal bias, so we can get into that later, is that without truly randomized control trials, it is difficult to give a strong recommendation, in my opinion, to recommend an FMT for an initial episode of a C. diff infection. And then when we take a look at what they are going for the first recurrence, is they discuss the taper pulse vancomycin, and then using fidaxomicin, and then also IV bezotoximab for recurrence as well. For any second or subsequent recurrence, vancomycin or fidaxomicin, followed by an FMT, and then repeat FMT for recurrences within 8 weeks. The repeat FMT for recurrences within 8 weeks was a conditional recommendation, but it was, again, a strong recommendation for the use of FMT with what they called a low quality of evidence. And so kind of the big differences between the ACG and the IDSA was the much more they had a focus on using FMT as their recurrence prevention versus the IDSA-SHA used bezotoximab as their go-to thing there. When looking at the European guidelines, it's the team that put these together, they no longer recommended metronidazole in any of their recommendations unless there were significant limitations. And so for their initial episodes, they also recommended fidaxomicin as the preferred agent versus vancomycin. And then for high risk patients in initial episode, they had fidaxomicin with bezotoximab at that time as well, completely eliminating vancomycin for high risk of recurrence patients. Again, I feel like all three of the guideline recommendations had the preferred option when not available to use metronidazole somewhere in there, but for their guidelines, they were very much against that altogether. And then for severe C. diff infection, they also talked about vancomycin or fidaxomicin with metronidazole. In Europe, tigecycline is also considered an adjuvant therapy for severe C. diff infection as well. And then the same for the severe complicated. And then for recurrence, they, again, have completely eliminated vancomycin at that time outside of doing the vancomycin taper and pulse regimen, but it's going to be standard of care plus bezotoximab for first recurrence episodes. And then for subsequent recurrences, they, again, go with the standard of care, but they were, FMT was something that they addressed at that time as well. And so just a little bit kind of on the CDI antibiotic prophylaxis. We didn't discuss this in the IDSA-SHA guidelines, but that was just due to the fact that there was insufficient data at the time to recommend extending the length of anti-C. diff treatment beyond the recommended treatment course or restarting any C. diff therapy empirically for patients who require antibiotic therapy. So no recommendation was given. As for the ACG, they did discuss oral vancomycin prophylaxis that may be considered during subsequent systemic antibiotic use in patients with a history of C. diff, who are at high risk of recurrence to prevent further recurrence. But again, it was a conditional recommendation with a low quality of evidence. And then it was just a good practice statement from the European guidelines for routine prophylaxis with anti-C. diff antibiotics when on systemic antibiotics is not recommended. And so the reason that I bring this up, so this is someone from my own clinic that I wanted to bring up. So it was a 57-year-old with spina bifida and a liver and kidney transplant back in 2020 who had developed diarrhea. And the overall course was he developed spontaneous diarrhea in March of 2021 with no antibiotics, no recent travel. He had a stool multiplex PCR, which was positive for both C. diff and for norovirus. He was treated with vancomycin, and he presented to my clinic in April, and he had no response to the vancomycin at all, which is typically a telltale sign that there is something else that is causing the diarrhea if they continue to have diarrhea while on vancomycin. At that time, we stopped the vancomycin. About a month after that, though, he complained of increased diarrhea and incontinence. We got a repeat stool multiplex PCR, which was at that time positive for C. diff, but negative for norovirus. We treated him with fidaxomicin, followed by resolution of the diarrhea. And so the hypothesis that we came up with that the initial presentation was norovirus infection and C. difficile colonization. Treatment with vancomycin precipitated a subsequent true C. diff infection. And so we took a look at the C. diff melt curves from the multiplex PCR. And so the peaks in this top one here are kind of more indicative of a low bacterial burden of C. diff at that time versus the higher bacterial burden of C. diff within the bottom one, which after discussion with the company, there was a higher likelihood of colonization based off of that discussion with them. And so that's why we always kind of want to be very, very careful about just providing prophylaxis, because a lot of the trials that are out there right now, most of them are retrospective. There are a couple of randomized trials that are ongoing right now, but we still need much more data before we're able to make an informed decision of how to target antibiotic prophylaxis in those patients as well. And we have increasing evidence that oral vancomycin is nearly as disruptive to the microbiome as a lot of our systemic antibiotics. And that is due to the remarkably high concentration of vancomycin that is achieved in the colonic lumen when we take it orally versus any other method as well. And so just a couple of off-topic things as well that just came up. So looking at the impact of COVID-19 on healthcare-associated infections in 2020, so there was a summary of the data reported to the NHSN, the National Health Safety Network. National and state level standardized infection ratios were calculated each quarter in 2020 and compared to 2019, and then the SIRS calculated for each healthcare-associated infection, reported infections predicted using 2015 national baseline data, and then the data represented by the change in the magnitude, and then the nationally from 2015 to 2019, significant reductions were seen in SIRs for Class Bs, CODs, and C. diff infections, the lab ID events. Keep in mind, I have the lab ID events started there, and the big reason why is that lab ID events for C. diff just means a positive test. So you're going to pick up colonization, and you're also going to pick up true infections with those as well. And so the data they have in there was actually quite interesting for a lot of these things. So we noticed that there was actually quite a significant increase looking at Class Bs and CODs over 2020, and then also, excuse me, but the surgical site infections all seemed to go down at that time as well. And then for laboratory identified C. diff went down pretty drastically, especially at the beginning of the COVID pandemic, and then it started to level off by the end of the year as well. And so why didn't we see an increase in C. diff during the COVID-19 pandemic, despite a lot of antibiotic usage just from our own institute alone? So a couple of questions that I think still need to be answered throughout all this. So we did notice a significant increase on the focus on hand hygiene, environmental cleaning, patient isolation, and use of PPE during the pandemic. Continued inpatient antimicrobial stewardship programs, which have already been shown to reduce C. diff infections prior to the pandemic. A decline in outpatient antibiotic prescribing during that time. People were scared to visit their doctors. People were scared to go to the hospital, primarily at the beginning as well, leading to a lower patient bed occupancy. And then not only that, we do feel there was a change in the hospitalized patient population as well. There was a halt on a lot of outpatient procedures initially, which seemed to have changed the typical type of patient that we were seeing in the hospital. And then we did see some impaired CDI treatment without laboratory testing as well, with people who had diarrhea, but a patient didn't want to come get a test done because they didn't want to come up to a hospital. And so the question that a lot of us have now is, will this relative decrease in C. diff continue, or will C. diff come back as we quote unquote return to normal, whatever normal actually means, and whenever that actually will happen as the COVID continues to remain an issue. And so what about looking into the future right now? So new therapeutic agents on the horizon for C. diff. So a couple of these right off the bat. So tolfamir, we discussed earlier, and sclerotomycin and catazolit all had disappointing results from a large multi-center, multi-country phase 3 randomized control trials, and they are dead in the water at this point right now. And so we are not expecting any of the three of those to come about if you have heard about those. Ranitidine, so ranitidine resulted in a higher observed sustained clinical response rates versus vancomycin, but did not meet the study's primary endpoint for superiority. We are expecting more information on that now soon. The manuscript has not been released, but there have been some top line results that have been from the company. Yeah, so Idph, which is just finished up a phase 2 non-comparative report of 10 patients with C. diff and had sustained clinical response at 28 days after treatment. So soon there will be a phase 2b trial compared to vancomycin, which again is a little bit of a question of why we're still using vancomycin as our comparator drug, but I think for the foreseeable future it will remain that way, but soon it will likely shift over to fidaxomicin. And then SER-109, which is an oral microbiome replacement, which was just released in 2 or 3 months ago, is showing that there was, as an adjuvant therapy, it had some significantly promising results as well. And so the phase 3 standard of care plus SER-109 versus just a standard of care, the SER-109 group had a recurrence of 12% at 8 weeks versus the standard of care at 40%. I would say that a 40% recurrence at 8 weeks is a little bit high. So it's not quite clear as to why that is just yet. And so I'm not going to go through all of these right now, but I'll make sure that the slides are shared after this as well. So if there are any questions on these, you can always go through them as well. But it's just looking at where we are in the clinical trials for some of these upcoming medications as well, and kind of things to keep an eye on in the future. Same thing in this one as well. I think that the RBX data, once we kind of finish putting all that together, I think it's going to be interesting, similar to the SER-109, but that's still a ways off right now. And then, so will there be a C. diff vaccine? So far, we have not had promising results. So Sanofi phase 3 C. diff toxoid vaccine had to be terminated early after the first plant interim analysis because of futility, with 34 C. diff cases occurred in the vaccine group compared to 16 in the placebo group. The Pfizer phase 3 C. diff toxin vaccine trial, a top-line result reported in March of this year, with 3 vaccines scheduled at 0, 1 month, and 6 months. Didn't meet its pre-specified primary endpoint of prevention of primary C. diff infection. However, secondary endpoints of medically attended C. diff and duration of C. diff symptoms showed a benefit of vaccine over placebo. And so I'm going to wrap it right about there. So if there are any questions that anyone has, feel free. I'm going to pop all of these up here. All right. Thank you. My moderator left. Yeah, I will share these slides. I didn't know that there was an issue. No one was chiming in, so it's hard for me to know that. I apologize.
Hi, Andrew. I'm not sure where Jamie went, but your slides were advancing for me fine.
Okay.
And yes, all the slides will be available, and everyone can watch the replays for up to 12 months. Does anyone have any questions for Andrew? She just texted me. She got kicked off for some reason.
Okay.
Any questions? If not, you can all head to the closing stage. I'll just briefly go over how to get CEU. But thank you for this presentation. From what I saw, it was great. I got to catch the last end part, and I really enjoyed it.
Thank you. All righty.
Everyone, please feel free to head on over to the closing stage or join one of the last sessions. We do have about 15 minutes. Some of those are still going on. So you can either jump into one of those sessions or go on to the stages and go to the closing stage.